Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. These are real conversations with physician experts from around the largest healthcare system in the Maryland, D.C. region. Trains, planes, and automobiles, more than 300 million people take a long-distance trip each year, taking a seat in a confined space for at least 4 hours, according to the Centers for Disease Control, and never giving thought to the health risks their long-distance travel imposes. Specifically, blood clots. In the same magical way our lifeblood coagulates to form clots that stop a cut from bleeding, a clot can form without an injury deep in our veins. It's called a DVT, or deep vein thrombosis. If that clot moves, it can travel to the lungs and become a pulmonary embolism. Now the traveling plans become a medical emergency. The risk of stroke, heart attack, and death are very real. Today we are addressing DVTs during travel, how they're treated, and how to prevent them, with MedStar Health vascular surgeon Dr. Maggie Arnold. I'm your host, Debra.schindler. Dr. Arnold, welcome back to DocTalk. I read that some estimates put DVTs caused by long-distance travel to be about 1 in every 1,000 people. And that includes all types of long-distance travel. Is there a greater risk to travel by air to get what they call a flight clot, maybe because of the air pressure in the cabins?
I think that's a great question, Deb. And I think it also speaks to the fact that why you can sit in your office chair for 6 hours a day and not be at risk for DVT. But when you take that same duration in a flight, it does increase your risk. I think there are 3 main factors involved in increasing the risk from DVT on an airplane flight. The first one, as you mentioned, is the cabin pressure. So there's a lower level of oxygen in the air that may start the clotting cascade in your body. The clotting cascade is necessary, just as you mentioned. If you have an injury, you need to clot to stop from bleeding to death. But if that gets started prematurely because of changes in the pressure, then that can start off a cascade that can lead to a blood clot that shouldn't be there. The second and third, I think, are really the most important. The second is the immobility that happens when you're on a long flight. So if you think about traveling in your car versus traveling in an airline seat, you probably are a lot more comfortable sitting in the front seat of your car than you are in the middle seat in the coach class of an airline flight. There's much less leg room, you have much less ability to move, and you really sit still for long periods of time. And I think that is the number one risk factor for when you're traveling, especially by air, that leads to DVT formation. And the third is dehydration. So again, if you think about the number of times that the flight attendant may come down the row with a small glass of water versus when you're traveling by car or even by train, you have the ability to get up. You may go to the beverage car, you stop at a rest stop and get out and move around and get a drink of water. You're drinking a lot less and you're moving a lot less. And those two things, dehydration and immobility, I think are the biggest risk factors for DVT formation while you're flying.
So is someone on a train, for example, maybe in an RV going cross-country, are they at less risk then, even if they're sitting still?
So they are at less risk, mostly because if you think about the amount of time you move in those situations, you are probably moving more. But I do see patients who have taken long car rides who have developed DVTs. If you travel for a long period of time in a still and immobile position, you are at increased risk for DVT formation than if, say, you're on a train ride, but you get up every now and then to go to the bathroom, to go to the cafe car, even just to move around. But it also is a lot easier to be mobile on a train. There are a lot more restrictions when you're flying in terms of just being in your seat. The flight attendants don't really want us moving around the cabins anymore like we used to. So it's a lot harder to just get up and move on an airplane as opposed to being on a train. Or if you're traveling in your car, just the ability to stop and get out at a rest stop.
What are some other risks that might impact getting a DVT?
Sure. So I think the biggest risk can be obesity and smoking are two of the biggest risk factors. Obesity, especially if you think about plane travel and how confined that makes you compared to somebody who might be smaller and have more mobility in their seat. If you're a larger person and you're in a small airline seat, your mobility is even more restricted. The reason that you get blood clots that form is because the veins really need that movement in order to circulate the blood. And the more confined you are and the harder it is for the veins to return the blood to the heart, the more likely that stagnant blood is to clot.
Are you seeing patients from a certain demographic or age group that are more likely to get a DVT? What about women versus men?
So it's usually pretty balanced between men and women. I think older patients are more likely to develop DVT, but I think that also speaks to the fact that older patients may be less mobile than younger patients. So it really does come back to the mobility. There are other risk factors that are involved. So patients who have a history of cancer have a higher risk of developing DVT, and older patients are more likely to have a history of cancer, so their risk factor goes up. The other special population is women on birth control medications, because those can increase your risk factor of getting DVT.
Some of the other risk factors that are listed include high cholesterol, high blood pressure, prior central line placement.
Yes. So I think those are some risk factors, but I think if you look really at the biggest risk factors, smoking, obesity, and oral birth control pills are probably the biggest risk factors. Those other ones are smaller risk factors. Central lines are catheters that are embedded in the large veins in our body, and they help deliver fluids when we need them. And they can cause scarring inside of those large veins, and the veins become narrow, so they're more likely to develop clots. When I'm looking at big population-based risk factors, the biggest one clearly, especially in our American population, is obesity.
I recently traveled to Ireland with my parents who are in their 80s, and I was more worried about them and the DVT than myself. But in reading this and in preparation of this podcast, I saw that anyone over the age of 60 is at risk.
Yeah, I know. All of a sudden, being old takes on a new meaning when you look at the medical. What is medical for? I don't feel old, but, as we get, the closer you get 60, I think, again, a lot of it comes down to mobility and movement and what your other risk factors are. So, the important thing is to make sure that you're moving.
For the first time, I went out and got some compression stockings for the flight. But how do they help?
I'm so glad you brought that up. So I get asked this question a lot about compression socks. And I will say, I definitely don't think they hurt, but they are not going to be the solution to preventing DVT. When you wear compression, it decreases the volume inside of the veins in your legs because they give you a little squeeze on the outside. But if you wear compression and you still aren't moving, you're still at risk for DVT. So I think that they can help, but they shouldn't be what you do to prevent DVT. The best thing you can do, if you can get up and walk up and down the aisles, that's great. If you can't, if there's restrictions on whether or not you can get up, even just doing calf exercises and leg circles in your seat and moving your legs, just being stationary in your seat but moving your legs can be great. I always tell this to my patients, your calf muscle is a pump, and it's responsible for squeezing those veins in your legs and really initiating that blood flow back to the heart. So the more you can activate your calf pump, the more you're circulating that blood through your veins.
Shoes on or shoes off?
Depends how tight your shoes are and how comfortable you are. I always take my shoes off on long haul flights, but then my feet get cold. So if you have shoes that have a lot of wiggle room in them, I think it's fine to leave them on. If you feel more comfortable, take them off.
What about taking a blood thinner?
So I'd only advise taking a blood thinner if your physician recommends it. Some people take a small baby aspirin. I don't think that there's a lot of risk in that, but that's not necessarily on its own going to prevent blood clots. If you have a personal family history of blood clot or a personal history of blood clots, it's something you may want to discuss with your primary care physician about whether you should be on a blood thinner. But I certainly wouldn't take your friend's blood thinners before you get on a flight.
How long does it usually take for a clot to form? And does it happen during travel or
So most likely the clots form during travel. You may not notice it right at the time. So I will often see patients who will come in, maybe they traveled a week ago and now they've started to notice pain in their calves. And that's because the small clot that had formed is now sort of like a snowball gathering clot along the way. So you have a nidus of clot and then the clot grows enough to where it becomes symptomatic. Most of the time when people notice symptoms a week or so after they traveled, it's not that they developed that clot a week after travel. It's that it's finally become large enough that they've become symptomatic from it.
Okay, so when they start to notice it, it's because they're feeling a pain in the calf, most commonly?
Most commonly you will get is calf pain. So the two most common symptoms for blood clot in the leg are going to be calf pain and also swelling. So those are two signs. If you've had a significant amount of travel, you notice some leg swelling and you have some calf cramping, I always advise people, don't think it's just a muscle cramp. If you have those two things and you notice your leg's a little bit more swollen, go in and be seen by a physician.
What are some other symptoms of a DVT?
So those are the two primary symptoms, would be calf pain or calf cramping. Oftentimes it feels like a cramp, and swelling. Severe DVTs, very large DVTs, can lead to significant swelling and even discoloration of the leg. Those tend to be later symptoms. You could have like a bluish discoloration because if you think about, if you ever put a rubber band around the tip of your finger and your finger turns that bluish purple, that's the same idea. So you have decreased venous return from your leg, and it's sort of becoming swollen and filled up with this dark venous blood.
Is there heat associated with it?
Does it feel warm?
Yeah.
Most of the time, no. It's more like a cramp sensation and swelling as opposed to like a hot.
You don't feel that from your touching the skin?
Right. You wouldn't feel it from touching the skin. Yeah.
Okay. Once a person detects that or suspects that they have a DVT, what's the first course of action? So
the first thing I would think, if you are concerned you have a DVT, call your primary care. If your primary care is available to see you, great. If not, I would go to an urgent care. And I'll also say all of our MedStar urgent care centers are connected with our vascular surgeons. So if they suspect you have a DVT, we have a pipeline to get people in, because the next step that you really need is an ultrasound. So we use ultrasound to diagnose DVT. You could also go to an emergency department and our emergency departments also have ultrasounds to evaluate for DVT.
Should someone panic? Is it a real 911? When is it a 911?
If you have calf cramping and mild swelling, you certainly could be seen in our urgent care. If you have significant leg swelling and discoloration, you should call 911.
Is walking going to exacerbate the problem or put you at a higher risk for an embolism?
Such a great question. And this is a question I actually get asked by doctors, because we have patients in the hospital who have DVT and all of a sudden they're put on bed rest, which is actually the opposite of what you want to do. So you want to get up and move. Moving is not going to increase your risk of pulmonary embolism, but it is going to decrease your risk of that clot propagating or growing. Because again, you want your muscles moving. You want the veins circulating the blood. What you don't want is immobility. So as soon as you put somebody on bed rest, now they're immobile. Now they're still at a higher risk for developing new blood clots.
How does a DVT become an embolism?
So sometimes the clots get so big and they sort of break off of the wall of the vein where they're attached to, and that's when they embolize. So an embolus is just something that's moving through your bloodstream. Why some DVT become emboli and some don't, I don't know.
And then it becomes trapped in the fibers of the lungs?
So then it goes to the venous system drains into the lungs. And so it gets trapped in the blood vessels that feed the lungs. And that's a pulmonary embolism.
And that's very dangerous.
That's very dangerous and can be life-threatening. Yes.
What happens then?
So it really depends on where it is in the lungs and how symptomatic a patient is. But here at MedStar, we do what's called a thrombectomy, where we can go into the lungs with a tube that's called a catheter and actually directly remove the blood clots.
Oh, wow. Okay, let's get back to the DVT.
Yes.
What would be the course of action to remove it or dissolve it?
Yeah, that's a great question. So again, a lot of it depends on where the DVT is and how symptomatic a patient is. Smaller DVTs, generally we treat with just anticoagulation. And there's different types of anticoagulation depending on what your situation is. And the medical provider would prescribe that for you. Larger DVTs that are in more central locations can be treated with thrombectomy. And that's a decision that gets made by the interventionalist. So it's either a vascular surgeon or an interventional radiologist. Sometimes at MedStar, we both perform these interventions, and it will really depend sort of on where that DVT is and how symptomatic someone is to determine what the next treatment plan is.
If they do have to get a thrombectomy, is that does that require an incision in the leg, or are you going in through the artery?
So we do a minimally invasive approach. Instead of, it's not an incision, it's really just a puncture site, similar to getting a catheterization. Many of our listeners have probably had a cardiac catheterization. That's the same. So if you think about it, it's around the size of a pencil. That's how big the device is that we use. And I'm really proud to say that MedStar is involved in a nationwide clinical trial looking at the best treatment practice for DVT. It's called the Defiance trial. And we're one of the main centers for this trial that looks at using these devices to directly remove the clot. The benefit of it is it doesn't have to involve clot busting medications, which can often increase patients' risk for stroke. It's just a mechanical removal of the clot as opposed to using clot busting medications, which again can cause life-threatening problems like bleeding in your head, which is a stroke.
Is there anything that we should share about enlisting in that study?
So any patient who is seen by in our MedStar facility who has a DVT, if they contact vascular surgery, they will automatically be a candidate to be enrolled. But if you have a DVT and you'd like more information, the trial is called the Defiance trial. And you can certainly call our office and we'd be happy to look at your testing and see if you'd be a candidate for enrollment in the trial.
What about femoral filters? Are we still doing them?
So they're filters, they're IVC filters, they're inferior vena cava filters. They go in often through the femoral vein, but they're placed centrally in the inferior vena cava, which is the main vein that drains the blood from your legs and takes it back to the heart. The IVC filter, I usually describe it as an umbrella that doesn't have any fabric on it, or like a bird cage. And the goal is to catch large DVTs as they're traveling out of their leg to prevent them from getting to your lungs. So they don't stop small clots, but they do stop the large life-threatening ones. We, in general, try to minimize the use of filter placements because anytime you put a foreign body inside a blood vessel, it in and of itself becomes a risk factor for forming clots. And most of the time, the filters that we put in are called retrievable. So we put them in, but we always try to take them out after the patient is outside of their window for risk of a major DVT or PE.
Which is usually how long?
It depends on the circumstances. So I can give you an example. A patient who has had a major orthopedic trauma and also has a head bleed. That patient needs to be on anticoagulation because they're very high risk for DVT. But because they've had a bleed in their head, we don't want to give them blood thinners. That patient would be a good candidate for an IVC filter. And then once their window of risk of head bleed has gone down or they're more mobile from their orthopedic injuries, we can remove their filter. And that's really a decision that gets made with the treating physicians. And we usually have a conversation about how long we need to leave it in. So the IVC filter doesn't stop you from getting a DVT. It just stops that DVT from going to the lungs.
From traveling. Mm-hmm. If a person has a DVT, are they then at risk for it later in life? Are they now one of those people who have a propensity to clot?
Absolutely. Good question. And I would say, again, it really depends. So if you got a DVT and you were in a situation where, let's say you were the patient who had orthopedic trauma, we call that a provoked DVT. So provoked DVT happened in a circumstance where you're more likely to clot. You had a orthopedic procedure. You were on a very long car ride. And these circumstances where your clotting cascade gets activated, but it's within the circumstance of elevating your risk factors is called provoked. An unprovoked DVT is somebody who is living their everyday life and then develops DVT. Those patients are more likely to develop DVT in the future, and we typically leave them on blood thinners for longer than for patients who had a provoked DVT. The other recommendation I would make is if you have a DVT without any substantial risk factors, that you should talk to your primary care provider about doing a workup to see if you have some state, we call it a hypercoagulable state, where you're more likely to form clots than other people because you may be a person who needs to be on blood thinners for life.
You know, I was just thinking about what you said. Sometimes the clots can form during the flight or during the travel. Maybe a person has a week or 2 weeks in the place that they are traveling to and they are feeling that clot in their calf. Should they get back on the plane when it's time to go home?
If you, let's say you were recently telling me about your wonderful trip to Ireland, I would say in most places that we travel, unless you're in a very remote location, you should be able to get an ultrasound. I think that's the benefit of worldwide access to healthcare, is that in most places it's very low technology to get this testing done. So unless you're in a very remote location, you should be able to get an ultrasound to evaluate to see whether or not you have DVT. But if you are experiencing those symptoms, say you traveled, you've been there a week, now you have significant, calf pain and swelling, and you think it's not a muscle sprain, but it is something you're worried about, you would want to find a local healthcare provider that could do a workup for DVT.
And then the ultrasound, say in Ireland, discovers you do have a DVT. I shouldn't fly home?
They'll probably put you on. I think you should always stay in Dublin. That should be always the right answer. Right. They would start you on blood thinners. And then once you're on blood thinners, you can certainly go back on the plane.
Okay.
Yeah. But you probably need to stay in Ireland for at least a month to make sure that they're working okay.
I'm calling out.
Do it.
I recently saw a TikTok trend that was getting some news attention because it had millions of views. And that is where people were making recommendations on how to get comfortable on these very confined. The seating in planes now is so tight, so small, that in order to sleep or to get comfortable, people were making recommendations on TikTok that you lean back in your seat, pull your knees up to your chest, and put the seatbelt around your ankles.
Well, I have to say that doesn't sound comfortable at all. So I'm not sure who thinks that's comfortable. Maybe small children.
Young people.
I would definitely not recommend that because you really are now, one, immobile, and also you're really decreasing the ability of your veins to return the blood to the heart. So I think if we're talking about risk factors, I say that is one TikTok trend I would not recommend following.
Good advice. In summary, what are the takeaways people should know about DVTs and traveling?
So I think the big takeaway is don't be afraid to travel, but just be smart about it. If you're able to get up and move around during the flight, if you have a situation where you can't, do calf circles or calf raises. A lot of airlines now actually have pamphlets in the seat backs, but you can also download them online, just simple exercises you can do in your seat, and make sure you stay hydrated. Things like caffeine and alcohol can definitely cause you to be dehydrated, so try to avoid these when traveling and drink plenty of water before and during the flight to make sure you're staying hydrated, and move around as much as you can.
Which would also require you to move around.
Exactly, because you got to go to the bathroom.
That little teeny tiny bathroom.
That's right.
Thank you, Dr. Arnold.
Absolutely. It's always a pleasure, Deb.
We've been talking with vascular surgeon Dr. Maggie Arnold. Thank you again for sharing your expertise with us here on DocTalk. If you would like to schedule an appointment with Dr. Arnold and you're anywhere in Maryland, she has several locations. Call 443-777-1900.